Thank you very much for being here on a beautiful afternoon. With the weather outside, I'm surprised that so many people are in the room. I want to begin by thanking Sophia, in her role as the director of the USC Institute of Global Health, and her team for the invitation. I'm honored to be here, and I'm honored to be sharing the podium with Jeff O'Malley, who is one of the great leaders in the HIV response, and I've had the privilege of working with Jeff for almost 20 years now, and you will understand why he's so remarkable when he speaks. So, the 2030 Agenda. In September 2015, 193 UN member states, countries, unanimously adopted the 2030 Agenda for Sustainable Development, ushering in what is often said to be a new era of global cooperation. The 2030 Agenda for Sustainable Development succeeded the Millennium Development Goals, or the MDGs, which in many ways laid the foundation and contributed to the ambition of the 2030 Agenda. So what's new in this agenda? Well, the MDGs were 8 goals. The SDGs are now 17 explicitly interconnected goals with 169 targets. Sounds quite daunting. The MDGs were much more narrowly focused, but included 3 health goals. They were often criticized for not having a strong sense of legitimacy. So learning from this in the development of the 2030 Agenda, the UN undertook an extensive consultation and engagement with a range of constituencies to develop the priorities for the 2030 Agenda, the SDGs. And as with human rights, the agenda is universal and indivisible. So it's for all people and for all countries. The MDGs focus largely on low and middle income countries, whereas the SDGs, the 2030 Agenda, the Pledge to Leave No One Behind, focus on all countries, high, middle, and low income countries, and least developing countries. The other new thing about the agenda, of course, is the strong focus on sustainability, as is suggested by the title. Sustainability bringing together the 3 interlinked strands of development: economic development, environmental development, and social development. But what's really exciting for someone like me that's very excited about human rights and health is that the 2030 Agenda, the 17 Sustainable Development Goals, and the pledge to leave no one behind and reach those furthest behind first, much more explicitly than the MDGs, incorporated human rights in multiple ways. First, there was a rights-based process for the development of the agenda. The process of consultation for the 2030 Agenda involved 10 million people across the world, from low, middle, and high-income countries. The 2030 Agenda is strongly anchored in human rights with clear language on equality, non-discrimination, universal respect for human rights, justice, and human dignity. It's anchored in a full respect for international law. And it has 3 specific goals on reducing inequalities, promoting gender equality, and peace and justice. In addition to the strong language on human rights and the rights-based process that was used to shape the 2030 Agenda, there's a powerful pledge to leave no one behind and reach those furthest behind first. Vital to delivering on this pledge is the use of disaggregated data. So there's a very strong emphasis in the 2030 Agenda, the SDGs, to use disaggregated data, partly to determine who is being left behind and who's being left the furthest behind. Another important feature of the 2030 Agenda is that it includes an expansive and possibly the most expansive list of groups in an international document of its kind, and calls for the empowerment of these groups. And I've listed some of these groups on the slide. However, it's important to note, while the agenda does include an expansive list of groups, inevitably some groups, such as LGBTI people, minorities, are not included. However, also important to note that the agenda does include the use of the term other in multiple places, which afford the opportunity to include groups that are not otherwise listed and included. And as I said earlier, the use of disaggregated data is also another important way of including groups that are not otherwise listed in the agenda. So the SDGs explicitly reflect human rights commitments from 9 core international human rights instruments. And I've got a slide up here with the first 3 SDGs on eradicating poverty, zero hunger, and well-being for all, health and well-being for all, which show what human rights instruments are implicated in these 3 SDGs, and we could do that for all 17. The 169, and this is probably the most powerful inclusion of human rights in the agenda, the 169 targets of the 17 SDGs, which are vital for performance and monitoring, are also really, really strongly anchored in human rights. 92% of the 169 SDG targets are specifically linked to international human rights instruments and human rights standards. So for example, in the context of health, SDG 3 on health and well-being includes a target on access to safe, effective, quality, and affordable essential medicines and vaccines for all. So I wanted to spend the rest of the presentation talking more about HIV, perhaps one of the wicked problems of global health, and I know the school is looking at wicked problems. One of the targets in SDG 3, target 3.3, is about ending the epidemics of AIDS, TB, malaria, neglected tropical diseases, hepatitis, and waterborne disease. Since the beginning of the epidemic, the HIV epidemic, more than 74 million people have acquired HIV and 35.4 million have died of AIDS. And I was just looking at the population figures. That's roughly 10 times the population of LA City and maybe 4 or 5 times the population of LA County. So a huge number of people have died. The global response to HIV has been remarkable on a number of fronts. An unprecedented mobilization of people, especially people living with HIV within and across countries. A demonstrable power in terms of multi-sectoral responses to address drivers and impact of HIV. The response has demonstrated the power of human rights and rights-based responses to address vulnerability, risk, and impact of HIV. The response has also demonstrated the power of solidarity across governments to address global problems. And the value of setting bold targets to drive progress. So just as an example, in 2003, the World Health Organization set a target of putting 3 million people on antiretroviral treatment by 2005. And at that time, people thought it was absolutely insane. Antiretroviral treatment was not widely available in low and middle income countries, and there was actually quite a lot of pushback saying that the health systems in these countries were so fragile and so weak that it simply would not be possible. And what was the point of setting such an ambitious target? Because it was unachievable. In the end, we didn't get to 3 million people on treatment by 2005, but we did something quite remarkable in terms of really demonstrating to the world that it was indeed possible to put people on treatment, a significant number of people on treatment in low and middle income countries. So the power to set bold targets is important. Critical also for the SDGs as well. So where are we today with HIV? We have 36.9 million people living with HIV at the end of 2017. 21.7 million people accessing antiretroviral treatment in 2017, and I think the 3x5 target had a lot to do with that. 1.8 million new infections in 2017, and really new infections are not going down as quickly as we need them to be, and that's important because we will measure progress against SDG target 3.3 on HIV against new HIV infections. So we really need to get prevention to work. We have new tools and scientific developments which can significantly help us reduce new infections. But HIV prevention remains chronically underfunded. In addition to that, 47% of these new infections are in key populations, which is a term coined in the HIV world, referring largely to sex workers, transgender people, people who inject drugs, prisoners, and gay and other men who have sex with men. Populations that are at greater risk of HIV for a range of social and legal factors, and populations who bear a disproportionate burden of HIV. Now the 47% figure is high, but it's not really as dramatic as the situation really is, because the 47% is a global figure, and it masks actually alarmingly high rates of HIV in certain groups and certain places. So for example, in Eastern Europe and Central Asia, and Middle East and North Africa, where rates of HIV are still rising, the only 2 regions in the world, 95% of new infections are in key populations, which is quite shocking. So at a time when there's a growing recognition that there's a need to invest more to reach these populations who are typically criminalized, marginalized, and excluded, and to promote and protect their rights, which is critical to reaching these populations, we also have the problem of a rise of oppressive laws and policies, like the Global Gag Rule, like the crackdown on civil society, which has really been at the core of the response to HIV. So a confounding challenge. So in the case of HIV, those left furthest behind are key populations, young women and adolescent girls in sub-Saharan Africa. There's an urgent need to increase investment in services and programs to reduce their vulnerability and risk. And as stated in the 2030 Agenda, to empower these vulnerable populations. So part of the solution is to make better use of the law, which has been an otherwise underutilized tool in the global response to HIV. In 2012, the Global Commission on HIV and the Law, for which Professor Gruskin was on the technical advisory group, found that laws and policies informed by science and evidence and grounded in human rights were a cost-effective tool in the fight against HIV. The Commission called for an end to the overly broad criminalization of HIV and outlawing the discrimination that increased stigma, risk, and vulnerability. Since 2012, more than 89 countries have taken action to implement the Commission's recommendation in some way or the other. For example, in some countries, HIV criminalization laws have been repealed. Several other countries have recognized the right to comprehensive sexuality education. Other countries have passed laws to protect women from violence. And other countries have decriminalized adult consensual same-sex relations. Much more needs to be done to ensure that countries' laws embody the vision of the 2030 Agenda of universal health, equality, and human dignity. So I wanted to end on a few reflections, forward-looking reflections. In spite of the progress achieved, HIV is still an epidemic of exclusion, inequality, and marginalization. And it's becoming more and more acute and visible in the epidemiology. As optimists, because I think people who work in global health are ultimately optimists, we must embrace and really take advantage of the SDGs and the pledge to leave no one behind, and use it as a framework to finish the job on HIV, especially taking advantage of the strong anchoring in human rights. SDG target 3.3 is not the only part of the SDG agenda that's relevant to HIV. The commitments for gender, the goals around gender equality, ending inequality, eradicating poverty, achieving peace and justice are all relevant and can all make a contribution to ending AIDS. So we need to look at the totality of the agenda and see how we can use it. But I want to end on a caution, and that is the story of resources and financial resources. The SDG agenda comes at a time when overall assistance, development assistance, is going down. No matter what the OECD would like to tell you, it's not flatlining, it's actually going down. Resources for HIV are going down. So, in essence, what's left in the HIV response is the really tough job. It's reaching the marginalized, people who are hard to reach. So, we need the resources to do that. Now, on the one hand, it's good because there's more and more domestic investment in the HIV response. 56% of resources for HIV, according to UNICEF, come from domestic budgets, which is fantastic. We now have to find a way of bringing in the SDGs and the commitment to leave no one behind to make sure that we have the resources to finish the job on HIV. And I think it's a real challenge because we have to find a way of finding the synergies and connecting the dots across some of the key targets and the key SDGs, which will help us to end the inequality and the marginalization, especially around the most vulnerable populations in the context of HIV. So I'll stop there. I'm not going to give you
You heard from Sophia, and you saw in the flyer that I'm going to talk about the links of the SDGs to LGBTI issues. And you might wonder why on earth is somebody talking about queer people or queer issues linked to the SDGs? I mean, how do these two things fit together? And I think there are at least a couple of reasons. First, I think looking at the relationship between queer and intersex people in the SDGs is a way of testing this framework, this Sustainable Development Goal framework. And you can ask yourself, how does this framework work for people with disabilities? How does it work for the elderly? How does it work for racialized minorities? How does it work for migrants? How does it work for queer people? I think different people, of course, have multiple different identities. They're not just one or the other of those things, but looking at any of those categories is a way to test, to see, does this framework make sense for everyone? Does the language about leaving no one behind, does that really work out when you translate this into reality? I think for me, there's another reason I want to talk about queer people and the SDGs, and it's because I'm a gay man who spent over 30 years working in health and development work. And I've never, in over 30 years, had LGBT or LGBTI in my job description. But as Mandeep and Sophia know very well, I've managed to drag a little bit of queer stuff into a remarkably wide range of jobs and into everything from quite conservative UN environments and quite activist NGO environments and elsewhere. And for me, I dragged it in, of course, out of personal commitment, but also out of a strong belief that, as I'm working on a range of issues, it's perfectly reasonable for me to work on issues that are near and dear to my heart, and indeed the issues that got me involved in HIV work in the first place. Let me start by going back to Mandeep's remark and going back even further in history. Mandeep talked about the MDGs, the Millennium Development Goals, which preceded the SDGs. But I want to go way, way back to the middle of the 19th century for a minute. And the middle of the 19th century was when imperialism, colonialism from the European powers was really at its peak. And it's also the time when somebody named John Snow, those of you who study public health know this story, discovered and demonstrated that a cholera epidemic in London was linked to a water pump in a slum in Soho. And that was the beginning of public health. That medicine wasn't just responding to somebody with an illness, but it was tracing the track of a disease and understanding, in that case, the environmental context that actually made an epidemic happen. So you had public health and colonialism and imperialism really happening at the same time. And part of colonialism was taking care of our soldiers, if you were a white European, and our settlers, and making sure when our soldiers come home domestically that we're dealing with the diseases they're bringing home, whether that's syphilis or the plague or whatever else they're bringing home. And I'm mentioning all of this because the roots of global health are not altruistic. It's not about helping poor people or helping marginalized people. The roots of global health are about facilitating colonialism and imperialism. And as you go through, public health, right up until today, the security elements of public health remain a driving force for why rich countries engage in public health. There was a very important turning point in the HIV epidemic in 2000 when the United Nations Security Council held a Security Council meeting on a health issue for the very first time, and that was on HIV. And the fact that HIV was posed not just as a health issue, but as a threat to security. There were army people and military people that are talking about how HIV was a threat to our troops, it was a threat to political stability. That's what catalyzed the big scale-up in the international response to HIV. It wasn't a concern about poor people in other countries dying. The woman right now who runs the United States government's global AIDS program, PEPFAR, who also ran it not just under Trump, but under Obama. She's one of the only officials that Trump held over from the Obama era at a senior level. She's a colonel in the army. And there, again, there's a reason that you see this intersection between the military and public health. So when you talk about global health, you're talking these days, since World War II, about two different narratives at once. And they're not always in tension, but it's important to remember both of them. One is a narrative about protecting rich countries and the military and global trade and global commerce from disease. And the other is a narrative that really emerged after World War II with the language, the codification of human rights, the Universal Declaration of Human Rights, and at the same time, the codification of development thinking. Not, for those of you who come from fundraising, in our UN world, development doesn't mean raising money. Development is the word we use for working in low-income and middle-income countries to try to, again, traditionally advance economic development, but as Mandeep said, increasingly pay attention to the environment and social development as well. So you've got this essentially altruistic rationale for health work, and along with a self-interested rich country rationale. And they can be at odds with each other, but they can also be very powerful together. In the last 100 years, the average life expectancy around the world has more than doubled to over 70 years old. And it's a remarkable achievement. And there's a lot of stuff in development that's really difficult in terms of poor communities, poor people, poor countries. But it's important to step back and just recognize how much we've achieved globally in terms of improving health, including health for the poorest. Mandeep talked about what was called 3 by 5, trying to get 3 million people by 2005 on HIV treatment. But then she talked about what the numbers are right now. And although 3 million wasn't reached by 2005, it was reached by 2007, and 10 million people right now, over 10 million people, are being kept alive and healthy and productive, thanks to antiretroviral therapy. And a lot of that, by the way, is financed by your tax dollars, if you're American taxpayers. Because, again, President Bush launched this PEPFAR thing, bringing in the Army, as well as CDC and USAID and other actors. And the US hasn't done it alone, but the US has absolutely been the global leader in that. So you have these security and altruistic things going together. What's all this got to do with queer people? Partly I just sort of like the history. But I wanted to set the real big picture context of this discussion. When I started working in HIV in developing countries in the 1980s, really the only people, not the only people, but a huge proportion of the people paying attention to these issues were like me from the LGBTI community. And there were a handful of public health doctors and others. And as the international response to HIV grew, there were always a lot of LGBTI people involved in the response, including, of course, in countries where the epidemic overwhelmingly didn't impact LGBTI people. But because in certain countries, including mine, Canada at the time, my community was disproportionately impacted, I got involved. One of the things that was very striking as you move from the 80s into the 90s was, on the one hand, there were a lot of queer people involved. On the other hand, there was a very strong glass ceiling if you were out of the closet. Because there was a narrative that HIV affects everyone. And there was a political calculation that if we talk too much about how queer people are affected, that's going to reduce public support for responding to HIV. So yes, we want queer people to work hard and to be involved, and we, appreciate their activism. But let's make sure it's sort of straight white doctors who are the public face of this global response. And queer issues were also ignored by the mainstream donor community in terms of developing country responses to AIDS. And that had serious consequences because the HIV epidemic wasn't so serious among many of sex rich men, amongst trans women in the early days of the epidemic in Africa. And now it's become much more serious because those populations were ignored and excluded for so long. Mandeep mentioned this phrase, key populations, and a group of us came up with that phrase in the mid-90s, and I'm proud of it, I'll say, because until then, the public health language had been target groups. Who are we targeting with our interventions? And the idea of key populations was that there are groups of people who aren't just disproportionately affected by HIV, but they're also key to the response to the epidemic. And a lot of people right now in these key population groups are tired of that language, and they feel that language is as stigmatizing as target group language was. And that happens. Language changes, and we need to understand, and we need to evolve our language with time. But it was an important conceptual shift. The HIV epidemic, for all of the problems, for all of the glass ceilings, for all of the homophobia, for other things, ended up being an amazing, I'm sorry, it sounds strange, but positive force for a recognition of sexual and gender diversity around the world. And that includes absolutely in Africa, in Asia, in Eastern Europe, every part of the world, in the United States. The reality that HIV made this diversity visible was very important. And to go back to my history lesson a moment ago, the fact that you had military people and public health people and crucially epidemiologists, the people who play with the data, pointing to the importance of these populations and saying you need to do something about it, it meant it wasn't possible to deny anymore that this diversity is part of our society. I don't care if you're in Malawi, if you're in Thailand, if you're in the Russian Federation, it became, what was invisible became visible. And it was remarkable over the course of the late 90s into the 2000s, how even in a lot of countries where homosexuality isn't only stigmatized, but where it's very deeply criminalized, dramatically criminalized. I mean, we've got, I think, a dozen countries in the world that have the death penalty for same-sex relations between men, 8 countries that actively use the death penalty for consensual adult same-sex relations. Anyway, but even in some of those countries, you started to have ministers of health talk about and include queer people in planning HIV responses. And that was a remarkable step forward. That brings me to the SDGs. HIV remains incredibly important, as Mandeep explained, and roughly, not quite, but almost 1 million people from key populations a year are being infected with HIV. And you've also got a lot of people still dying of AIDS. You don't sort of feel that living in Los Angeles, but globally that's still the case. Huge success at scaling up access to treatment, but 1/3 of the people who need it still not getting it. And so you've got this kind of strange dynamic going on right now. In Africa especially, I'm going to talk about Africa in my concluding remarks here because that's where I've been working mostly the last few years, where on the one hand there's been this tremendous progress politically thanks to HIV making groups more visible and more politically involved. But you've also got a lot of resentment amongst a lot of gay and bisexual men and trans people in particular that they're only seen as HIV and that nothing about them other than HIV is seen as important. And so with the SDGs, on the one hand, it's important that we continue the HIV response and continue to recognize that HIV disproportionately affects certain populations. But we also have to say, again, queer people are also people who live in poverty. They're also people who suffer from gender-based violence. They're also people who suffer from climate change, and so on. And there are a number of issues where queer people are disproportionately affected. Not climate change. You know, if you live in the Maldives, I don't care if you're gay, straight, or asexual, you're in trouble. And your sexuality has got nothing to do with it. But there's a whole bunch of issues where it's pretty clear, and I say pretty, that you're probably further behind if you're queer, on average. Because there's a lot of queer people who get bullied in schools, or people who are presumed to be queer. And they drop out, or they don't perform as well. You're not educated as well, you don't do as well financially. A lot of queer people have difficulty getting jobs in a lot of countries and a lot of sectors. There's a massive problem with queer people getting and maintaining housing. People think of equal marriage rights as something that's about marriage or about sex or about family. They don't necessarily think of it as an economic issue. But if you can't establish a family and a household, that actually also affects you economically, and again exacerbates poverty. So all of these things are true in addition to your disproportionate vulnerability to HIV, especially again if you're a gay or bisexual man or a trans woman. And so the SDGs in their complexity and their vastness, they're sort of intimidating, but they give us a whole bunch of opportunities to say, hold it, if you're concerned about putting the furthest behind first, and including the most marginalized, it's important that you understand that that's often the case with queer people. Now the last thing I'm going to mention is something about data, which Mandeep already mentioned disaggregated data. A moment ago I said it's pretty clear that queer people are often the furthest behind or disproportionately far behind. And the reason it's only pretty clear is because there's a tremendous lack of data. A lot of what I just said is intuitive. You know, if you drop out of school or get kicked out of school, if you don't have access to housing and so on, you're probably going to suffer disproportionately from poverty. But we don't know. We have better and better data about sexual minorities and gender minorities in some rich countries. But it's very hard in most countries of the world to even know whether queer people disproportionately suffer from poverty or what happens with education. And it's not always a negative story. There's some very interesting data that exists that queer people in a lot of African countries have a much higher rate of migration from rural areas to cities. I moved from middle of nowhere Canada to Montreal because it was Disneyland. You know? But when you move to a big city, in fact, your economic opportunities go up. So there's things about being marginalized which might actually give you opportunities. In this country, traditionally, gay and bisexual men earned less than straight men. Transgender women in particular earn dramatically less than cisgender women, and of course cisgender women still earn less than cisgender men. The exception to this was lesbians in this country. So for many years, lesbians on average have earned more than heterosexual cisgender women. It's almost certainly because lesbians on average have babies less often. And heterosexual cisgender women pay a big penalty in terms of their earning power by having babies. Now, very recently in the United States, it appears that gay men, all of a sudden, are actually earning more than straight men. So if any of you are hesitant about coming out, it's okay now. But in other countries around the world where there is data, gay men continue to earn less. So we need to, but this is rich country data. So the only way we're really going to make progress in these areas is to have better understanding, better data, better insight, and a recognition that all of these intersectional lenses do matter. Again, I'm talking about sexuality and gender identity here, but you could just as easily talk about a whole bunch of other categories. And we have to talk about all those categories if we're going to take the pledge and the promise of the SDGs seriously.